Thank you. So it's lovely to be here. Thank you so much for the invitation to come and speak to you all. And I'm going to talk about methoxyflurane. How effective is it? What's the cost of inhaled methoxyflurane compared to usual analgesia for pre-hospital injury and trauma? So my name's Niro Siriwardena. I'm a Professor of Primary and Pre-Hospital Healthcare at the University of Lincoln, and I lead the Community and Health Research Unit. And until recently, I was Associate Clinical Director at East Midlands Ambulance Service, and I've been there for around 15 or 16 years. My background is as a GP, but I've worked in pre-hospital research for some years now. I'm going to give you a little bit of background and then talk about our evaluation that we did of Penthrox at East Midlands Ambulance Service. First, I'd like to give some acknowledgements. So the person who did all the econometric analysis, the statistical analysis, is Dr. Murray Smith, who works in my team at Lincoln as Senior Research Fellow in Health Economics and Econometrics. And Dr. Elise Rowan did a lot of work with the database. At EMAS, Rob Spate, who's a part of the study, and we've had great help, of course, from many paramedics working at EMAS. So I'm really grateful to them. The study was funded by Galen, but Galen had no role in the study design, conduct, or reporting. And the views that I'm going to present here are those of us who did the evaluation and not necessarily those of the funder. So I think looking at all of the names and the places that you came from and some snippets about your experience, I think many of you already know about Penthrox, and many of you as people working in pre-hospital and emergency care will know about trauma pain. So acute pain is present in most of those attended by emergency medical services for traumatic injury. It's often inadequately treated. And the barriers to pain relief, you'll know, things like problems with pain assessment, contraindications to the regular drugs that are used, limited choice of analgesia and delivery routes. And we know that sometimes patients refuse to have analgesics because they want to turn up in A&E in pain, rather than having their pain settled before arrival. And there are all sorts of interesting reasons why analgesics either don't work or aren't accepted pre-hospitally. And potential solutions include expanding the range of analgesics available, and that's where we come to methoxyflurane. Many of you will know that it used to be used as an anesthetic, but as an anesthetic it caused problems in much higher doses than are used in analgesic doses. It's been widely used as a painkiller in adults and children for many, many years, 4 decades in Australia and New Zealand. And what's been found there is it's easy to administer, it has a good safety profile, and more recently, it had a European license for emergency relief of moderate to severe pain in adults with trauma pain. But one of the things that's been limiting its use pre-hospitally, and ambulance services have been reluctant to use it here, is the lack of evidence of clinical and cost effectiveness in the pre-hospital setting. And that's the reason why we wanted to look at this. I think ambulance services were crying out for more information about the costs and the effectiveness of methoxyflurane. Now, there has been a lot of research on methoxyflurane, particularly in the emergency department. A number of randomized controlled trials have been published over the past few years, and here are some of them. And what they found was that methoxyflurane relieved pain more quickly or more effectively, or both, compared with usual analgesics. There was a systematic review conducted by Keith Porter and colleagues, which reported that Entonox, as pre-hospital methoxyflurane, was superior with pain relief at 15 minutes for methoxyflurane, superior pain relief at 15 minutes for methoxyflurane. And a previous observational study suggested that methoxyflurane was inferior to morphine when used pre-hospitally. So there's a little bit of uncertainty about the pre-hospital effectiveness. And so we wanted to investigate the clinical effectiveness and costs of inhaled methoxyflurane delivered by ambulance staff for patients with trauma and associated pain. Does it, and does adding it the usual analgesia improve pre-hospital pain relief? Does it offer good value to the NHS? So what we did was we implemented methoxyflurane over a period of around about a year, and we've done an observational comparison comparing Entonox and parenteral analgesics that are used at EMAS. That is IV morphine and IV paracetamol. We looked at verbal numerical pain scores over time in adults with moderate to severe trauma pain, and ambulance staff were trained in giving methoxyflurane and supplied with it over the course of the study. We then looked at comparator pain scores from the database over that same time period, the database of all patients who presented with pain due to trauma. And then we used what's called an audit probit panel regression model to see the effectiveness, looking at pain scores. And then we looked at some scenario analyses to compare durations under severe pain, with analgesia, and to look at the costs. So how did we go about doing this? 96 clinicians were trained to deliver methoxyflurane as part of the evaluation, 45 paramedics, a student paramedic, 50 emergency medical technicians. I think it was important that we included technicians because compared to paramedics, as many of you will know, their access to pain relief is much lower. Obviously they can use Entonox, but can't use intravenous drugs. So here's the checklist for Penthrox, looking at contraindications and indications for the drug. So it's indicated for adults, kidney impairment, reduced consciousness, elevated temperature, hypersensitivity, cardiovascular problems, lung or respiratory impairment, liver impairment, or where there's been a recent administration of methoxyflurane. So those were that was the checklist that was used to make sure that the drug was used within the indications. We were supplied with 520 doses of Penthrox, and 510 were prepared for administration, and in all 501 doses were administered. 58 patients got 1 dose, and 21 patients got 2 doses. And 45% were given methoxyflurane as the sole analgesic. And you can see that 4.4% got a double dose, and very few of the drug doses were wasted, 9 out of 510. A little bit about timing of administration. It was given first line for 89 patients and last for 142. Mostly it was given at the scene of the incident, but sometimes it was given during conveyance, and occasionally it was given just before handover when the patient was at hospital. So a little bit about the control data. as you can imagine, we had a lot of control episodes from East Midlands Ambulance Service where Penthrox wasn't given. And we were able to select patients, all the patients who were indicated for treatment because of their condition, trauma. So similar conditions that the patients with methoxyflurane criteria. And we managed to get 1,833 episodes in which the only analgesic used was Entonox, morphine, or paracetamol for comparison. And so here are the numbers that we eventually looked at in the regression models. So methoxyflurane 479, Entonox 700, 278. And you can see the differences in those groups in terms of sex and age breakdown. The methoxyflurane group was slightly younger on average than those given morphine or paracetamol, slightly older than patients given Entonox. There were slight differences in sex breakdown. You can see that the pre-administration pain score for methoxyflurane was a little bit higher than for Entonox, morphine, or paracetamol, and you can see the mean pre-administration pain scores. And you can also see that that's reflected in the severe and moderate pain scores at onset. You can see also in these descriptive tables for Penthrox compared to Entonox or morphine or IV paracetamol. So that's about something about the patient characteristics. A little bit more about patients who were given methoxyflurane, and we categorize the trauma into limb injury or fall or soft plus or minus soft tissue injury, suspected neck of femur or hip injury, head, neck or back, multisystem, multiple trauma assaults, stab wounds, etc., abdominal or chest injury, soft tissue, thermal injury. So that's how we classified the different types of injury so that we could compare like with like across the groups. And in terms of pain scores, we asked paramedics to score pain before they gave analgesia at 5 minutes and at 30 minutes. And you can see that sort of worked pretty well for Penthrox. So here's the scores around 5 minutes. Here's the score at baseline, and here's the score at 30 minutes. But as you can see, there are a lot of pain scores taken during the course of the episode, and I think that says something about how good paramedics are at recording pain. And here are the frequencies of the numbers of pain scores that were taken. But similarly with, and this is a routine comparison group with Entonox and with morphine or paracetamol, you can see that lots of pain scores were taken throughout the time course of receiving treatment. So that was good. One of the other things we did was to include, as well as Penthrox and other drugs, we were able to control for multiple drugs given. And we did that by using this pain score influence table. What we did was to look at the summary product characteristics of the various drugs to see how quickly they worked and also how long they lasted for, so that we could control for that in the analyses. And then what we did was to develop some scenarios to look at the effect of Penthrox compared to the other drugs in terms of their effectiveness. we did this through development of a series of models, and we call these scenarios or predicted pain pathways. And I'm just going to run through the first one to explain what this shows. On the y-axis, you can see the pain score, and on the x-axis, you can see the time in minutes. 0 is the first pain score, and 0 is the time at which the drug was administered. And what we're looking at here, this line drawn across the graph here, is the point at which pain goes from severe, that's pain scores of 7, 8, 9, or 10, to moderate, 4, 5, and 6. And you can see that with methoxyflurane, actually the pain goes from severe to moderate in around 10 minutes. For Entonox, it really never quite gets down to below severe if Entonox is the only drug given. And so you can see the duration of severe pain for methoxyflurane is about 10 minutes. The time to least pain, which is this trough here, is around 27 minutes. For Entonox, it's around 45 minutes. And you can see here the differences in level of least pain. You can also see these asterisks show the level of significance in the difference between these two numbers, and 3 stars means it's less than 0.001. These models account for the initial pain score, the trauma category, those 6 trauma categories that I showed, the age of the patient, the sex of the patient, and any other analgesics given. So we try to control carefully so that we could compare like with like in terms of the analgesics and the effect of them. Here's the scenario for intravenous paracetamol and the predicted pain pathway. And this is an exactly comparable graph. You can see that with methoxyflurane, which is in pink, and these are the 95% confidence intervals here, the time to meet this threshold from severe to moderate pain is just under 10 minutes. Whereas for paracetamol, it's 37.5 minutes, 27 minutes with methoxyflurane, 46 minutes almost with intravenous paracetamol. And again, very significant differences there. I mean, you can see that there are big differences in timings in terms of the time that people are in severe pain. And then it's slightly less marked for intravenous morphine compared to methoxyflurane. But again, you can see it's around 10 minutes in severe pain for methoxyflurane before you get down to moderate pain. And for morphine intravenously, it works a little bit quicker, doesn't it, than paracetamol, much quicker than Entonox, but it's around 20 minutes. So if you remember from the previous charts, to get from severe to moderate is around 10 minutes for methoxyflurane, around 20 for morphine, around 37.5 for intravenous paracetamol, and you never quite get there with Entonox. So what about side effects? We were able to get recordings of side effects that were recorded by the clinician on the case report form patients, so that's 6.7%, and of those 19 had to discontinue due to side effects. Some patients, mostly those over 75 years, didn't comply with the instructions for the whistle, which Penthrox is administered through, so they struggled to use it for various reasons. And you can see here the types of adverse effects that you get. Most common was cough, then altered taste, nausea, feeling funny, dizzy, drowsy, dry mouth, headache, etc. And some much more uncommon, such as anxiety or discomfort in the mouth or paresthesia. But overall, the reported side effects, clinician reported side effects, were less than 1%. I'm just going to move on to costs now, the costs, relative costs of the different drugs. We estimated the cost of methoxyflurane to be $18.89 per patient. That's a little bit more than the actual cost of the drug in the BNF, but it was based on the usage rate and the fact that some of the doses were not used and some were wasted. The cost of Entonox is around about £6.60, and we assumed here that you had to add a breathing filter, a mouthpiece, half a canister of Entonox, half a 2 litre, I think it is, canister per patient. And then there were costs of bottle refill and rental. Now, depending on how these things are costed, those costs can vary, but it just gives you an idea about how we worked out the costs. And so you can see that for methoxyflurane, the cost is around about £12 more expensive. Morphine was £7.70 per patient, and that included the fact that for some patients they needed paramedic backup to administer an intravenous drug if there wasn't access to Methoxyflurane. And so there was about an £11 difference. Similar difference for intravenous paracetamol. It's slightly less of a difference if patients had both morphine and paracetamol IV, and there were a number of patients who did. It's around £10 different if you looked at combined morphine and paracetamol or either separately. So what are the conclusions from our evaluation? I think I will point out the observational data and methods, and there are potential confounders in terms of bias in selection of patients and so on. But as you can see, we try to control very carefully for age, sex, initial pain score, all the other analgesics used. Of course, there may be some bias in terms of reporting of pain scores, the fact that paramedics knew they were giving methoxyflurane, or emergency medical technicians may have made them feel that the pain score or record low pain scores. So those are the sort of limitations to the study that we did. But as I say, we tried to carefully account for as many differences as we could. But overall, methoxyflurane acted around 4 times more quickly than Entonox to reduce pain from severe to moderate, around 3 times more quickly than IV paracetamol, twice as quickly as IV morphine. And importantly, both paramedics and EMTs were able to implement the use of methoxyflurane. Adverse effects were pretty low, and they did lead to the drug being stopped in 3 out of 5 of those with side effects, but that was a small number, 4% stopped. And the benefits were achieved at a higher cost, between £9 and £11 compared with usual analgesics. So again, acknowledgements and thanks to the team who worked on the study, and to say the study was funded by Galen, but they had no role in the study design, conduct or reporting. And thank you very much indeed to everybody for listening. And I'm really happy to answer any questions.